Welcome to the first ICRS TV episode in the series The Wonderful World of Cartilage Restoration and Joint Preservation, hosted by our education partner Winglet. My name is Christian Lademan. I'm the Chief of Sports Medicine at the Brigham and Women's Hospital and at Mass General Brigham in Boston. And next to me is Daniel Günther, the Chief of the Knee Department at Cologne Medical Center in Witten-Herdecke. And the two of us will be moderating this first episode live from beautiful Munich in Germany. The topic of our first episode is preserve or replace in the aging athlete. The debate continues. We have two outstanding faculty to teach us today. Tom Meines from the Paley Institute in West Palm Beach in the USA, Professor Emeritus from Harvard Medical School and immediate past president of the ICRS.
And Mike McNicholas from Liverpool University Hospital's Broad Green. He's the president of the Biological Knee Society and leads the cartilage registry of ICRS.
So Mike and Tom, welcome. It's a great pleasure to have you guys here. So a couple of housekeeping items. The format of the next couple of hours will include two lectures from our faculty with short breaks halfway into the lecture, and then some viewer question polling, as well as a series of case presentations with viewer participation and voting on what would you do, followed by Q&A with our experts. And before I ask Tom to talk to us now, we would like to ask you to vote on the first subject matter question. When you see a patient with bipolar chondral defects, the weight-bearing X-ray still intact or early narrowing, or multiple isolated chondral defects, and they fail steroid injections with physical therapy or biological injection therapy that includes MSCs, PRP, or HA, what would you do surgically? A, appropriate joint arthroplasty, unicondylar patellofemoral total joint. B, isolated osteotomy surgery. C, microfracture with osteotomy. Or D, a biological repair with cartilage transplant and osteotomy. And now, while you are deciding on this, without further ado, we will get started. We would like to invite Tom Meines to lead off with his presentation, Limits of Biological Reconstruction in the Aging Athlete's Knee with respect to age, activity level, and extent of repair, wins, and losses. Tom, take it away.
Good day. This is Dr. Tom Meines, and I'm here today to discuss joint preservation in those young patients who have early arthritic change with biologic repair as opposed to total knee arthroplasty. These are my disclosures, and they are relevant to the discussion, Varicel as well as my Elsevier book on joint preservation. So as we know, knee articular injuries in athletes are quite common. As much as 36% of injured knees have articular injury. And there's a high incidence of post-arthritic osteoarthritis, especially in the ACL injured knee, as high as almost 90% as we get out to 20 years. Return to sport, of course, is the goal with our young athletes, is the most important outcome parameter. So where do we stand? So choosing the correct treatment for me is generally using chondroplasty as a first line of defense to see how much just a gentle cleanup can help. And when it's a surface treatment without bone involvement, ACI is my favorite option. The lesion size and the age of the patient, of course, factor into this the most. Once we start getting larger lesions, ACI or allograft are the options I think that are the best to use. And background factors, as we've talked about for so many years, are important to recognize, otherwise treatment failure usually is the outcome. So we need to look at malalignment, meniscal status, ligamentous status, and of course the activity level. Throughout the world, of course, cost becomes an issue as well as availability of these options for patients. The wins, so ACI allows for resurfacing of large defect areas and including bipolar defects, and I'll get into that in my discussion because that's what we're talking about today, is early osteoarthritis in the young adult. Hopefully we can delay the need for joint replacement and we can increase exercise duration for patients older than 50 following ACI. That's been shown by Petska. But the thing here is these lesions are much smaller than the ones I generally treat. Here we can see 4 centimeters squared per knee, and they excluded kissing lesions, which generally are the ones we're talking about when we're talking about biologic preservation of a joint versus total joint arthroplasty. Now, here's such an example. This 50-year-old marathon runner comes to see me with a varus knee, near bone-on-bone changes on the medial compartment of his left knee. He's had to give up running because of persistent pain and swelling, and so what do? So here is the reconstruction that's required. You can see this is a bipolar lesion. We've corrected his alignment with an osteotomy, just restoring his mechanical axis to neutral, or when there's joint space narrowing like this in large lesions, I overcorrect by just no more than 2 degrees to get his mechanical axis to the top of the lateral tibial spine. You can see here we've done transosseous drill holes for suture passage for these uncontained defects on both the femur and the tibia. Post-operatively, management's important. The number one thing is motion. Make sure that they get their motion back. And I use an unloader brace for the tibiofemoral lesions to maintain that space and decrease pressure across the joint surfaces. So what does it look like 1 year post-op? You can see his alignment is restored. His joint space medially is completely restored. His 1 year MRI scan shows restoration of articular cartilage on the femoral surface and the tibial surface, and we have a very happy patient. When we looked at our bipolar lesions overall and published this in American Journal of Sports Medicine, we found that the patients were generally older, on average 37 years old. BMI was 26. We had 56 patients here, a mix of men and women. And you can see these are large defects per knee as opposed to Pet's good series on unipolar defects. These bipolar lesions are much larger, 16 centimeters squared per knee on average, and we had medial bipolar and lateral bipolar defects. We can see overall 10-year survivorship in 58 knees was about 80% 10-year survivorship. But the interesting thing, this included our periosteum, and when we excluded periosteum and looked just at collagen, our collagen survivorship at 5 years was 97% versus only 60% in the periosteum. So the advent of second generation technique markedly improved our survivorship with bipolar lesions. Here's such an example of another patient, bilateral knee, lateral joint pain with valgus malalignment. He was unable to participate in Taekwondo, which was his passion because of what he noted was 8 out of 10 pain with sports. And even with work, he complained of 4 to 6 out of 10. Arthroscopy revealed on the right knee, he had a lateral femoral condyle defect and valgus. On the left knee, he had lateral femoral condyle, lateral tibial plateau, and no lateral meniscus. So we staged his reconstruction, starting with the less involved knee, the right side. And you can see here, this was his lateral femoral condyle defect in a varus-producing opening wedge femoral osteotomy. And then we staged his opposite side, which was bipolar plus a meniscus transplant and an osteotomy. And here's the final result after completion of both of those surgeries. And we have a patient who becomes very active once more after rehab.
Also, now we go with the voting results. We had the question, when you see a patient with bipolar chondral defects, what would you do? And when we see that the majority of you would do a biological repair with cartilage transplant and the osteotomy, it sounds like, Tom, you have already convinced most people before your talk even that this is the way to go. Well, what do you say to that?
It's nice to see that after lecturing and talking about this for 25 years that people are agreeing with me. So I'm a little surprised by those results. I honestly thought it would be more biological injections persistently or going on to joint replacement. But it's nice to hear that in these younger patients, people are more interested in joint preservation, which I think is great.
Yeah, and then a question to Daniel. So Daniel, you practice in Europe. Tom and I practice in the United States. Would you do a case like the one that Tom presented? Would you do that in a single or in a two-stage procedure?
Well, we usually go for a two-stage procedure in most of the cases, but it's mostly because of the German reimbursement system. And sometimes it's difficult because if you take, for example, cells for a cartilage transplant, you have to combine it in the first stage with an osteotomy, and because you get reimbursed a little bit more then, and then in the second procedure, you can go back into the joint and do the cartilage transplant then. But that's mainly the reason lies in the German reimbursement system. Besides that, it's absolutely a perfect plan to do it like you presented us.
Fantastic. And so now we are going on to the second portion of Tom's talk, and we'll take it away right here.
So for bipolar patellofemoral defects, we have equally good results between November of 1995 and June of 2014. Roughly 20 years, we collected 155 patients with bipolar patellofemoral transplants. We excluded tibiofemoral and just kept this as isolated bipolar, leaving us with 58 patients, 60 knees. Our average age was about the same, 36, 37 years old, and follow-up about 9 years. And we found in patellar defects, the defects roughly were 5.6 centimeters squared, and these were the category in Fulkerson, the type 4B lesions, which were essentially panpatellar damage in 82% of the group, meaning that isolated osteotomy alone would not be effective to unload that patella as it's panpatellar, and this is where articular reconstruction is necessary. The trochlea, 4 centimeters squared, so roughly about 9 to 10 centimeters squared per knee. So here's such an example. This again is with collagen now. This is generation 2, and this is what they look like after resurfacing. Here's an example. A young collegiate hockey player presented with a 2-year history of severe worsening anterior knee pain, recurrent effusions, 8 out of 10 pain, and he had lateral maltracking, crepitus effusion on his exam. And so here's what it looks like when we open up the joint. You see he has trochlea dysplasia. His lateral trochlear facet is completely burnished. His patella is burnished. He has an overhanging lateral facet, which prevents reduction of his joint. So that has to go, and we transplant the surfaces and do a tubercle osteotomy. So here's what it looks like. We remove the osteophyte, a lateral facetectomy. That's an uncontained area of damage. Transosseous drill holes for suture passage on both the trochlea and the patella. The tubercle osteotomy. This is what the final reconstruction looks like. And here's what the x-rays look like. He's nice and centered now. And he did return to play and continues to do very well now more than 15 years post-op. So how do the bipolar patients do? Overall, again, about 80% good, excellent results. 10-year survivorship, almost identical to the tibiofemoral. But in my opinion, this is such a difficult problem to deal with, is patellofemoral disease. I think really this is a huge win. When we tease these results out a little bit, we found also that the very best results were collagen membrane as opposed to periosteum, but when we did everything at once, all at one surgery. So when we did the ACI with the tibial tubercle osteotomy as the first line treatment, you can see here if it was a failed TTO and we did ACI and TTO afterwards, the results dropped down. And if it was a failed microfracture or marrow stimulation technique with TTO, and then we did an ACI and TTO, the results are even less favorable, 43%. So the message here is do everything right the first time, realign the patella, unload the patellofemoral joint, and transplant them at the same time. So what we can't control, however, is progression of osteoarthritis in the aging knee. It's less predictable than traumatic defects. When we have degenerative lesions, what happens? When we look at return to sport as far as wins, you can see here pre-injury level, it's about anywhere from 1/4 to 2/3 of patients get back to pre-injury level of sports. But again, these studies that looked at this, just published this year in cartilage, are smaller defects. They're only 2 to 6 centimeters squared, much smaller than the defects that I'm used to treating. Here's a failure, 48-year-old former basketball player. You see a large MACI that was performed on his medial femoral condyle. He ended up with a fibrous repair and incomplete integration. We had to convert this with an allograft. Here's another patient who had progression of disease. We did a sandwich technique in 2000, and he was advised at that time to have a total knee replacement for osteonecrosis with a varus knee. We did the reconstruction, and 20 years later, when he had progression of disease, we converted this to a unicompartmental replacement. Our long-term results, the first group that I did, the first group of patients, 20-year follow-up, on average, again, about 12 centimeters squared per knee. Our 20-year survivorship was only 63%, but some of those that failed, we revised with cartilage repair once more, such that 80% maintained their native knee and 20% on went to joint replacement. What did they look like at the time of joint replacement? Well, here you can see the areas that are highlighted with an arrow are the transplanted surfaces. So 20 years later, the very best surfaces are the transplanted grafts, and everything in between has gone on to break down and degenerate. An example here of losses that I take right off the bat. 46-year-old male with a labor-intensive job. He comes to me. He's a fire building coordinator for fire rescue. His BMI is almost 40, 39. He has multiple comorbidities: hypertension, hyperlipidemia, obesity, sleep apnea, gastroesophageal reflux, and asthma. He really doesn't take very good care of himself. And so you can see his x-rays look relatively good, but he's got loss of articular cartilage on his tibial plateau with extrusion of his lateral meniscus. He's got a focal defect on his medial condyle. His patella has panpatellar cartilage loss. I think right off the bat, this is one that I would then proceed with total knee, which is what I did. So in summary, it comes down to patient demand matching. You need to know what you can do with the biologic repair that you have available to you, and try to meet the expectations of the aging athlete. And that means setting realistic expectations preoperatively, and that they can do the rehab necessary, selecting the most appropriate treatment, and looking at background factors, because in my series, half of my patients require osteotomies. And if you don't do the osteotomy with malalignment, the grafts will fail. And you need to recognize the many factors that affect functional outcomes in athletes, including motivation and post-op rehab. So I thank you for your attention, and I hope we have a fruitful and fun discussion.
Well, thank you, Tom, for the great presentation. And now we have to ask ourselves, what can we do if biologic reconstruction fails? It's an honor for me to introduce Mike McNicholas. In his daily practice, he performs not only arthroscopic joint preserving surgeries and osteotomies, but also a lot of knee replacement surgeries. So it's great having you online, Mike, and answer us one of the questions not only experts, but also patients ask their doctors a lot. Knee arthroplasty in athletes. What can we expect with respect to activity and limitations?
So hi, I'm Mike McNicholas, an orthopaedic consultant from the northwest of England, working in Liverpool and Manchester with a regional knee practice with an interest in arthroplasty as well as soft tissue knee and joint preservation treatments. I've been asked today to talk about knee arthroplasty in an athlete and what we can expect with respect to activity and limitations. These are my disclosures, none of which are relevant to today's talk. We know that almost a quarter of adults between the ages of 40 and 60 have a degree of arthritic change in the knee, and that in 2002, if that degree of mild medial joint space narrowing was present, on the balance of probabilities, 12 years later, that individual would have undergone a total joint replacement. Before any surgical intervention is carried out, we have to completely exhaust conservative management with each of the techniques discussed or mentioned in this slide here. One of the things that we are sure is that over time, there has been an ongoing improvement in revision rates in unicompartmental knee replacements, according to the National Joint Registry information that we have from the UK. Spahn's paper from 2011 said it took 12 years for partial joint replacements to be better than a high tibial osteotomy. And we can see that high tibial osteotomy, according to some people, gives better outcomes than partial joint replacements in patients that want to get back to return to impact sports. However, there are papers that show the contrary, and that unicompartmental knee replacement is actually superior to a high tibial osteotomy in allowing recovery and participation in recreational sport. And interestingly, looking at a massive study of over 70,000 patients from the Korean National Health Insurance Claims Database, they were able to see that high tibial osteotomy had a much higher risk of revision than partial joint replacement, both in 5 and 10-year follow-up periods, and that the rate of early complications with DVT and surgical site infection were significantly higher in partial joint replacement than a high tibial osteotomy. So what about total joint replacement? Well, whilst it's a great operation in elderly patients with high satisfaction rates, those in patients of 40 years old, only half the patients are satisfied with them. And the expectation that 85% of patients have of being pain-free, in reality is only met 43% of the time. And then thinking about the effects of these procedures on later operations, the revision of a total knee replacement is not affected by a previous high tibial osteotomy, as shown from the Norwegian arthroplasty register. However, revision following a unicompartmental knee replacement is less satisfactory than that after a high tibial osteotomy. And what about the very common issue of a cruciate ligament tear in an athletic population? Well, there are few rules known in medicine, but one of them was that a unicompartmental knee replacement for medial OA was contraindicated if the ACL was functionally deficient. And we know that without ACL reconstruction, there's a twofold increase in the failure rate of unicompartmental knees compared to if it's done in association with an ACL reconstruction. Mobile bearing unicompartmentals have a higher revision rate than fixed bearing. And so simultaneous or staged ACL reconstruction, although more complex surgery, gives superior outcomes, particularly in young and active patients.
So great talk so far, Mike. You mentioned an extremely important topic, which is patient expectations. So how do you address this topic in your daily practice? How do you talk to the patient to make sure that everybody's on the same page?
So I think, as Tom alluded to earlier, managing patient expectation is the most important thing to do when offering surgical intervention. And I basically say to patients that a knee replacement will give them the knee of a normal 60-year-old, and the level of function that they can expect would be that of a normal 60-year-old. If they are willing to accept that, then they're going to be happy with the knee replacement. And if they have unrealistic expectations, then I am not comfortable to offer them surgery because I'm not going to be able to meet those inflated expectations.
Totally agree with that. Perfect. So let's go ahead with the second part of your presentation.
Exercise recommendations after total joint replacement. There's a reasonable amount of literature that Marcus Custer is responsible for that helps us to understand that. And although patients should be encouraged to remain active in general health terms, it also helps improve bone quality, which would decrease the incidence of early loosening. But then factors that may affect total knee replacements are different to those of hip replacements. And the influences that cause wear, joint load, intensity of exercise, and the type of prosthesis have to be considered on an individual basis. Reduction of wear is what we're hoping to do to improve long-term results, and it's dependent, wear is, on the load, and it's influenced exponentially by the amount of load that the individual patient puts upon his knee replacement, the number of steps they do, the material properties of the total joint replacements may have an effect. And it's important to split up what activity they're hoping to do. So if they want to maintain physical fitness or endurance activity, they're probably going to be doing it a few times a week at high intensity, or low intensity for recreational purposes, which I think should be encouraged. So if we look at Custer's recommendations, then he has stated that the positives in any of these and subsequent slides show in green the activities that have been shown to be of use and recommended by surgeons, and in red for those that aren't. So swimming, cycling, and maybe power walking should be recommended, we felt. And if the individual is well practiced, then skiing and hiking could be performed, even though they're higher joint loads. People shouldn't take up technically demanding sports after arthroplasty because they're at a higher risk of injury. And the load and knee flexion angle are important. So in hiking and jogging, there are high loads occurring between 40 and 60 degrees of knee flexion. In many knee replacement designs, the arthroplasty's femoral component is not very conforming with the tibial polyethylene inlay, and high stress can occur. So he stated that regular jogging or hiking could cause high inlay stress with the danger of delamination and polyethylene destruction. And so it should be stressed that it's better to be more conservative after knee replacements than hip replacements when recommending activity. And this was one of the reasons that Custer was able to make that statement in a very interesting paper looking at 3 different knee replacement designs and Fuji pressure-sensitive film loading in different activities with the usual loading that the knee would see in those. 5 measurements were taken for each load situation. And they were able to state that cycling and power walking were safe, but that the loads in downhill walking particularly and jogging were not. So thinking about it some further and trying to suggest limitations, many authors have suggested, as Custer does, that our recommendations are really based on subjective opinion and not scientific evidence. The literature should be based on biomechanical laws, such as the previous paper that I've shared with you. And most knee replacement designs are increasing in their conformity towards knee extension. There are some exceptions to this, such as medial pivot knee replacement designs, and they may be better in young, active patients. But there's no literature to substantiate that clinically yet. So beyond a certain degree of knee flexion, conformity ratios decrease. And so the power walking and cycling, which produce the lowest inlay stresses, are the least demanding endurance activities. Jogging and downhill walking are high stress activities. And I'm not sure how you can do mountain hiking and avoid descents. I think it may be more sensible to suggest that while patients having had knee replacements are doing mountain walking, they use ski poles and come downhill slowly. And when consenting patients, you need to say that activity may pose a risk of additional wear and that could have long-term implications for the longevity of their implant. So there is some guidance, and if you look up the American Academy of Surgeons website, you can see what they have suggested, as you can see here. And the European Knee Society have a survey of 120 members looking at 47 different sports disciplines and subsectioning those into different time points after surgery. And the suggestions there in green are what they recommended at the various time points after the surgery. And so by 6 months after surgery, 21 out of the 47 activities that they were asked about were recommended. They were all in agreement that squash was not something you should be trying to play after having a knee replacement. This is the best and most recent summary of all the recommendations, and it's looked at 410 articles over the recent past. It's published in the BJJ Open, and it was published towards the end of last year. So I recommend that if you want to have a read. And then they were able to return to sport with a uni sooner than a total knee replacement, but both around about 4 months. Many of the patients with total joint replacements had pain during sports, and 42% of totals versus 24% of unis. Increased or maintaining sporting ability was possible in both groups. They both improved in terms of their Oxford knee scores, and they were far better if they had a uni than a total. And the senior surgeon carrying out the surgery was surprised to see that total knee replacement patients didn't return at the rate he would have expected them to in either golf or bowls, which he was surprised by. A large number of patients studied. Their mean age was 62, followed up again for about 20 months. And prior to the surgery, 81% of the total knee replacement patients had had sport in their life, and 90% of the unis. 83% of them were satisfied afterwards, and 85% had returned to a similar sports level. They were looking at the most common sports that were seen in these patients and found that cycling, swimming, and stationary cycling were those that were best returned to, and that 93% of patients were able to return to low impact sport, 63% to intermediate, and only 32% to high impact sport. The scores all improved, and regression analysis showed male sex, a high pre-op UCLA score, and more recent sports participation gave rise to high activity scores post-op, and that the elderly patients who were male and participating in low impact sports were going to be most satisfied, and intermediate and high impact sports were most often returned to by male patients under the age of 55. So in this study, they looked at return to playing golf, which is quite a common sports pursuit in our age range. And in this study, looking at 151 golfers, 93% of whom responded, over half returned to golf within 6 months of joint replacement, and 80% of them were playing as often or more frequently than they had prior to knee replacement. And they had an improvement in their pain, which is nice to see. And vast majority of them were enjoying playing their golf as much as or more than before the surgery. But then these are the surprising findings in this study. Prior to the surgery of knee replacement, 28% of patients were walking on the course. Despite reduction in pain, that figure dropped to 14% after the surgery. So most patients were using a golf cart, and the paper suggests that we should be getting them more active and encouraging more of them to walk the course. So if we look to see about tennis, another sport that many patients would like to return to, this paper's finding of relevance is in green there in the middle, that looking at a number of studies, they could find no evidence of harmful effects of return to golf on implant survival rates. And whilst returning to tennis may not be a goal for the average knee replacement patient, if they are fit and have a good motivated patient who's well practiced, that they shouldn't desist from playing tennis, but that we do need to study the effects further. But in the Canadian literature, downhill skiing after arthroplasty has been queried by members of the Alberta Orthopedic Society, 41 respondents, and they separated their answers in total and unicompartmental knee replacement as shown here. And the vast majority of them were happy to allow their patients to return to downhill skiing as long as they limited their speed and the intensity of skiing. They'd achieved a full range of movement and strength in the operative knee, and that they had some years of downhill skiing experience. They accepted that their recommendations are not really evidence-based, but again, surprisingly, 85% of them had never seen a complication from downhill skiing after either total joint replacement or partial joint replacement. So for me, running after a knee replacement is not recommended unless you're running out of the way of a bus. And so recorded revision rates, that's not relevant because nobody actually suggests that patients should do it. there is that mismatch in modulus of elasticity between the bone and the cement prosthesis interface, which will cause shear upon impact loading and early loosening. And polyethylene has been shown to have stresses beyond its yield point with jogging. So if your patient needs to do a fitness test for their employment that involves running assessment, they should use non-impact training such as the elliptical machine, flotation vest, pool running, and save the actual running for the beep test itself. If they do suffer an effusion or pain, they've got to slow down, back off, and any sign of radiological changes, they should stop and then consider a change in role. And then what happens this is, as far as I can find, the longest follow-up of what happens to patients with hip and knee replacements afterwards who try to remain active. And in this study, lots of patients have been active in their lifestyle, far fewer prior to their surgery. And although hip replacement patients maintained their sporting activities, knee replacement patients decreased their rate of participation very significantly. And there was a high level of pain suffered by patients having had knee replacements in attempting sport. So that's the end of my presentation, and we'll try now to answer any questions that may arise.
Well, that was an outstanding presentation. Thank you so much, Mike. And I have a question for Christian, actually. We heard a lot about returning to sports after knee replacement surgery. And now we talk about the aging athlete. And what do you think after an osteotomy? Do you think really an active athlete during his active career has any chance to return to a high level of sports after an osteotomy? What do you think?
Yeah, so it depends a little bit on what you call a high level, right? So I do believe that after an osteotomy, you certainly can return to high level sporting activities, and there's enough literature to support that. It becomes a little bit different when you're talking to the super highest level, of athletic activity in professional sports. There is concern that the motion patterns are changed after an osteotomy, and I believe the statement to guarantee a return to that level, I think, would be incorrect at this point.
Perfect. And now we would love to see one of Mike's cases. But before he is going to present us his case, I would love to ask the audience, how would you treat this patient? So this patient is a 49-year-old active police officer. He has severe bilateral tricompartmental hypertrophic knee OA, bilateral 10-degree fixed varus, and 20-degree fixed flexion deformities with flexion in total to 100 degree of flexion. And he wishes to remain on active duty as a firearms officer and close protection officer. To do so, he has to hit 9.5 on an annual shuttle run fitness test. He sees you for a second opinion, and he has been advised he's too young for knee replacements and no other options are open to him. What do you advise him? Do you advise him to retire because you cannot do anything for him, and maybe he can come back if he's 60? Or maybe do you tell him, let's try joint distraction? Or you tell him, I can replace your knees, but you will have to retire. Or replace his knees and tell him he has to change his role. Or maybe you replace his knees and then you tell him, I think you can stay in your current role. So what is your opinion on that? And in the meanwhile, Mike, you will present us what you did.
So thanks very much for the opportunity to present today a story of an athlete who went on to require a total knee replacement and hoped to continue in an active lifestyle. The second row, one of the tallest guys there in the middle, on the back row, just underneath the goalposts on the left, is the patient in his playing career for St Helens Rugby Union Club, which was one of the best clubs in the world at the time. And he played in the 70s and 80s and 91 appearances. And occasionally, given the nature of the game, he was in very difficult situations. And as you can see in the top left there, some punishing injuries to his knees resulted in the need for 3 arthroscopies in the left knee and 2 on the right knee during his playing career. He had numerous cortisone injections, so many that he lost count, given by the club doctor. He was occasionally asked to move forward, as you can see in the picture on the right, where he was stepping into the role of the hooker, who's the chap in the middle. And as you can see, in the 70s and 80s, pitch conditions weren't as good as they are now, which may be of relevance to his injured knee. He went on to retire after that professional playing career to move into the police force. And after working in the police force for many years, developed significant knee arthritis and was struggling with activities of daily living. He had seen a colleague who'd said, because he was only 48 years old, that he was too young for a joint replacement, and he had bilateral problems. And they were both very significantly arthritic knees with fixed flexion deformities of 20 degrees in each, a 10-degree fixed varus, and flexing to around about 110 degrees. So having spent a year trying to improve that conservative management, I'd failed to abolish his symptoms. And in 2008, he underwent a left cemented high flexion design of knee replacement, posterior cruciate sacrificing, without patella resurfacing. He had massive osteophytes throughout and needed those trimming, and in doing so, was able to improve his range of movement to 00140. So abolished his fixed flexion deformity and improved his flexion range to normal. After a year, he was ready to have the other side done. And so in 2009, 13 months after the first left knee replacement, at the age of 50, he underwent a right cemented knee replacement of the same design. Again, significantly hypertrophic osteoarthritis with a long operating time. But I was also, again, able to improve his range of movement on table to 00135. He worked hard at his rehabilitation, but unfortunately got a bit stuck. And around about 3 months, he'd only achieved 115 degrees. And he was keen to try and have a similar range to that he achieved on the other side. And so at about 4 months post-op, he underwent a manipulation and regained up to 132 degrees of knee flexion, which was he was very satisfied with, as was I. He went on to maintain his position within the Greater Manchester Police's hostage rescue team and working in close protection. And as you can see here, this is a picture of him where he was working, covering the G8 conference in Ireland in 2013, many years after his knee replacements. He had to achieve a beat level activity assessment of 9.5 for aerobic fitness on an annual basis. And he did so, having taken my advice, by non-impact activities to stay fit, get fitter, using bikes, cross trainers, and the rowing machine. And in his own words, he only ran when he had to, which that might have been every now and again in his work as a police officer and in his work in the close protection unit. After a further 10 years in that role, he moved into a office-based role and is still working with the police and still very happy with the outcome of his knee replacements.
Well, that's a great result. And now let's see what our audience did, if they agree. They say, I will replace your knees and you have to change role. So, Mike, what do you say?
Well, I'm glad to hear that the audience were more understanding than my colleague who'd refused to operate upon him. And I can understand that the suggestion of changing role is a perfectly appropriate one. But as a firearms officer, he made the point that he very often has something that doesn't make him need to run. The tools of his trade were going to help him in that regard. And he's now 15 years out. And so having had 10 years working in those roles that he loved, that were very valuable to society, so far, there's not been to the detriment of the longevity of his arthroplasties.
That is fantastic, and kudos to the patient themselves for returning back into that role and being as active as they are, because I think sometimes we underestimate how much it really takes on the part of the patients. We have participant questions, and I want to group these a little bit. Some of these are pre-operative questions, and that is mostly at this point to Tom. Tom, are there other MRI parameters that you are utilizing other than defect morphology in order to make a decision when to consider biological treatment? Is synovitis, for example, a relevant point?
No, that's a very good question. So synovitis or joint effusions, I definitely look out for those. That nearly always tells you it's the patellofemoral joint in my experience. So if you have recurrent effusions, they usually arise from patellofemoral cartilage loss. And if they're persistent, it usually means you're continuing to break down articular cartilage. My opinion is that when you start to degenerate cartilage, the small fragments, they get sort of self-cleaned out, they lie in the synovium, and they cause this inflammatory response. So if people continue to push through activity and their joint hurts or their joint swells, they are damaging their joint. So that is something I discuss with the patient, and I certainly look for patellofemoral damage when I see effusions. The other finding people ask me about all the time is bone marrow edema. Does that influence what I do? If it's bone marrow edema from prior marrow stimulation techniques, yes, I look for cystic changes and things like that are subchondral. Otherwise, what we have found is after repair of the cartilage defect and repair of alignment, usually bone marrow edema disappears after transplant. So those two things I think are important to me.
Fantastic. And then now a question to both of you. With regards to BMI, what BMI do you generally use as your cutoff for either cartilage repair procedures or for total versus partial knee replacements?
I'm still live, so I'll just start. So for me, we found that cartilage repair in patients with a BMI over 35, we had a high failure rate. So that's sort of our cutoff. And, obviously 35 is still quite heavy. But in the patellofemoral joint, it has less impact than the tibiofemoral joint. So if I have BMI of 35 and it's patellofemoral articulation and they're having a lot of pain and they're not super active, I'll still transplant the patellofemoral surfaces. But if it's tibiofemoral surfaces, I won't. That's probably when I'll go on to unicondylar replacement, osteotomy, or total knee. When it comes to total knee replacement, it depends on patient age again and BMI, but I treat BMIs over 40 regularly with total joint arthroplasty. But their goals are definitely not athletic. Their goals are really just pain relief and aerobic function, and the activities that Mike outlined in his excellent talk, cycling, walking, swimming, those are basically all the most they will do.
So I completely agree with the 35 cartilage restoration procedures. Some authors suggest 30, but I think they're excluding a lot of patients. And actually, BMI is a very poor measure of somebody's body morphology. And most professional rugby players have very high BMIs because they're so well muscled. I think that's probably the same for American footballers and a lot of contact sports people with high musculature. When it comes to joint replacement, in the UK, we've come to the decision that really, with a BMI of 40, there's quite a sudden and a very significant increase in potential morbidity and mortality for the patients. And so we would suggest to them that they should try and lose weight. Some of my colleagues say to get down to 30, which I think isn't very fair. My personal recommendation is to get to 35. But working carefully with my bariatric colleagues and a professor of diabetes with a special interest in obesity, we have patients that have had BMIs of 57 that get down to 45, and they're not going to get any safer than that. They eventually tail off at that kind of BMI, and then we've done everything we can to make the surgery as safe as possible. And so I am not absolute in my cutoff at a BMI of 40.
All right, thank you very much. And we will actually have a couple of cases where we can revisit some of the questions that we have gotten from the audience. So that was a great start to the session, and I thank our speakers for the insightful and thoughtful lectures. At this point, we would like to thank our sponsors, namely Regen Lab and the On Foundation as our scientific partner. And we will now take a short break. Go grab some water or coffee, and we'll see you back in 5 minutes. So welcome back again to the ICRS TV series, The Wonderful World of Cartilage Restoration and Joint Preservation. We are currently talking about the topic preserve or replace in the aging athlete. The debate continues. And we have seen some great cases so far and has some very wonderful talks from our featured speakers, Tom Minus and Mike McNicholas. We will now transition into an hour of interactive case presentations. We will have 4 case scenarios that we will share and discuss. I will now ask my co-moderator, Daniel Günther, to introduce the first case. Daniel.
Perfect. Thank you, Christian, for the kind introduction. So case number 1, these are my conflicts of interest. Here's the case presentation. This is a 50-year-old female former pro volleyball player. She has medial compartment pain in the left knee for 5 months, takes daily painkillers, BMI is 20. The clinical examination, free range of motion, medial meniscus pain, slight varus malalignment clinically. She's ligamentous stable. Patella grind test is negative. These are the preoperative X-rays. And if we take a look at her MRI, we can see meniscal extrusion and cartilage damage on the medial femoral condyle. If you measure it in MRI, it's 1.5 to like 3 square centimeters. And then we have a medial meniscus roots here. You can see the ghost sign on the sagittal view. If we take a look at her leg axis, we have 5 degrees of varus malalignment, an MPTA of 85 degrees, and the LDFA of 90 degrees, and a joint line conversion angle of 2 degrees. So what would you do with this patient?
Yeah, so now we have a live voting. So how would you treat this patient? Non-operatively, with a root repair and cartilage regeneration, a root repair, cartilage regeneration, and an osteotomy, or a unicondylar knee arthroplasty. And while you guys are voting and thinking about that, we can start the discussion on this case. And the first question that I have is to Daniel. Daniel, you've shown us the leg axis and the alignment and the slide varus alignment. Does the tibial slope play a role here for you?
Well, the tibial slope plays a role, absolutely. So if I would do the decision to perform an osteotomy, I would take a look at the slope as well, because I can address it in the same surgery, potentially. It always depends if I decide to do a femoral osteotomy or a tibial osteotomy, right? But the slope definitely plays a role at the end.
Yeah. And then question to Tom. Tom, what do you think about this case? Where would you go here?
Yeah, the one option that you didn't include there was osteotomy cartilage repair without root repair. That's probably what I would do. Yes, you can go ahead and do the root repair. Will it stop further extrusion? I think probably the most powerful thing is the osteotomy. And I have patients that are 20 years out that had an osteotomy and a cartilage repair and that had an absent meniscus medially, and they're still functioning well. So I really think the very powerful aspect of the repair is the osteotomy. So I would definitely do that. But now with some of the new outcome studies being done about meniscal root repairs and preventing extrusion and the devices that are getting better, if you have those at your disposal, probably that's the best option. But for me, I probably would just do the osteotomy and and the cartilage repair, I'm not sure that you would actually stop prevention in extrusion in a very active person.
If you take a look at the literature, you're totally right. The most important thing might be the osteotomy. But my point was, I would take a look into the joint anyway, so it doesn't take me too long to fix the root. So I would just combine it to make sure that if I can help the patient with a root repair, I will just do it. But you're right, if you take a look at the literature, the osteotomy might be more important.
Interesting is that there's some recent data that comes out of the Mayo Clinic actually that suggests basically that you should really do root repairs in any condition. So if you are doing the osteotomy, and this is a question to Mike, would you do an overcorrection or a correction back to neutral?
So I think she's 50 years of age. We haven't discussed the element of conservative management, and I think if she had mechanical symptoms, then I'd agree that we should start with an arthroscopy. But if there are no mechanical symptoms, then I'd start trying to see what effect an offloader brace had on her. And if the offloader brace was beneficial and she could tolerate wearing it, then that may be all that she needs to continue playing. And brace wearing is not contraindicated in volleyball, but again, that kind of depends on which position she plays. If the brace does allow her comfort, but she can't tolerate wearing it, it's still a valuable intervention because it gives you a very good idea of the prognosis for your osteotomy. And so I historically would have relied upon the osteotomy alone. And if they had persistent symptoms after a mild overcorrection, Rowley-Jacobs sort of surgery a la carte approach, where there's mild symptoms, mild joint space narrowing, do less of a overcorrection. But I would overcorrect her a little because of her age and the fact there are some signs of degenerate change there already. I would now, though, following on from Tom's amazing long-term studies, be more interventional, because the differences that you have in outcomes where you've done all the things that should be done, giving better long-term quality of life, mean that I think that now root repair, cartilage work, and a small degree of overcorrection would be what I would suggest.
All right.
The one thing about overcorrection that we haven't talked about is how much to overcorrect. If you look back to the Coventry osteotomy technique, he overcorrected quite a lot to the Kurisaka point, all the way into the lateral compartment on the downslope. That's really not tolerable for women. I mean, they hate you after that when they see how much valgus you put them into from varus, for sure. Yes, they give you longer functional pain relief. But the other thing is the kinematics that Christian alluded to earlier on, that you don't see too many athletes with valgus knees, but you see a lot of athletes with varus knees. And so just the motion that you have with a markedly overcorrected knee. So if I see any joint space narrowing, the most I will overcorrect them is just to the top of the lateral spine, just 2 degrees overcorrection. But otherwise, if the joint space is not narrow, I would just get it back to neutral and not more than that.
So we recently published a review of the literature, and osteotomy is very forgiving, and the traditional 3 to 5 degrees, or aiming for Fujisawa's point, on balance of probabilities, most surgeons don't achieve that, but patients are very happy. And so I think that as we understand it better, we are aiming to do less correction. Somewhat against that, though, there's been a number of long-term studies looking at if you achieve your desired correction and have a reliable technique, you can expect 20 years of good function for the patients from the osteotomy. Whereas if you fail to achieve that, then you are going to have, on balance of probability, 10-year survivorship of your osteotomy. So if you are aiming to be close to the midline or the 50% point, we're not as accurate as we would like to be, certainly not with conventional techniques. And so you may end up being in the diseased compartment, and then they will have a shorter longevity from their osteotomy. And something I wouldn't mind asking about is what about the use of 3D planning and patient-specific cutting guides, or other other ways of improving reliability, such as navigation?
That brings us to Daniel. Daniel, do you do 3D planning?
I do it in some cases, not in all of the cases. I do it especially if I have a combination, like if I want to do a derotation osteotomy, for example, and I want to correct the coronal alignment as well with a single plane osteotomy. And then I use a PSI usually, because in my hands it's quite difficult to combine both planes in one procedure.
Daniel, one final question. So does it matter to you where the majority of the chondral wear is? So if it is very far posterior and the patient mostly has pain actually on that side with deeper flexion, versus when it is more anterior and the pain is really more into extension, does that play a role in your decision whether you do an osteotomy here or not?
But in this case, actually it does not, because the meniscus root is there as well, so I would do for the osteotomy for sure. But so in this case, it would not matter.
Good, excellent. And I think at this point we can go on to the live voting results, and we'll see how would you guys treat this patient. Non-operatively, root repair, oh there we got it. Root repair, cartilage regeneration, and osteotomy. So everybody is really going for the complete restoration of this joint. Daniel, does that surprise you?
No, not really. But we have to mention that 30% of the audience would not do the whole package. Right?
That's correct.
That's an important thing. It's almost 1/3 of the audience. But yeah, I totally agree, and that's my case solution at the end. Step 1, I went into the joint and I did the diagnostic arthroscopy, and yeah, we know the meniscus root is not in place. And then I harvested the cartilage from the notch and I performed a high tibial osteotomy. I went to a straight back axis, neutral. And then in the second procedure, I fixed the meniscus root and I performed the second step of the cartilage transplant.
Great. So I think, at this point, we will be moving on to the final discussion of this case. Tom and Mike, would you have done that this way?
I would have done the final result is excellent. And I would have, I usually just do the arthroscopic biopsy at the first step and let them recover, and then just do everything at once at the second step so that they don't have too long recoveries. But otherwise, the result is excellent, Daniel.
And I agree, the scheduling that you've used there is great, because if you'd have done your root repair at the time of your harvest, then the patient would have an even longer period of restricted weight bearing and range of movement. So hiding those two recoveries in the same period of time is exactly what I would aim to achieve. So I'd agree with Tom. I think you've done exactly the right thing.
Great, fantastic.
Well, then the next case, we will go to the lateral compartment then.
All righty, so
you will present us an Amazon worker, which is sports in my eyes as well, right?
yeah, well, if you know what they actually do, you have to consider these very, very high activity, patients. So this is a 40-year-old male Amazon worker, has moderate activity, in recreational terms. He has progressive pain with walking, squatting, lateral-sided knee pain, increasing swelling. He has had 2 previous lateral meniscectomies at 8 and 4 years ago. In the past, he was a football player, so he is a little bit bigger. His BMI is 42. He reduced that to a BMI of 37 after 6 months of dieting. His long leg alignment is neutral. He presents with an MRI that shows essentially a normal medial compartment, has a significant absence of the lateral meniscus. This is a little hard to see, this is why I'm telling you that. The lateral chondral loss is in that high traffic corner, in that, where the lateral condyle intersects with that lateral meniscus just in front of the popliteal tendon. He has normal otherwise ligaments. This is his scope picture. So you see he has a lateral femur grade 3 to 4 changes, 2 by 2.5 centimeter overriding lesion into the meniscus weight-bearing area. Has lateral tibial grade 2 changes and a mostly absent lateral meniscus. So we have a patient who is 40, who has reduced his BMI. By the time that I get to see and operate on him, it's 36 at this point. He has neutral alignment, missing lateral meniscus, grade 3 to 4 chondral loss on the femur and beginning chondral loss on the tibia. He's clinically symptomatic, failed non-operative treatment, and he wants to return to work with pain-free ADLs.
So, wow, that brings us to the audience. Great presentation so far. What would you do? Overcorrecting, distal femoral osteotomy, chondral repair with cell-based or non-cell-based technique, chondral repair with cell or non-cell based technique and meniscus substitution, or just do in uni. What would you do? And then during the voting, Christian will tell us what he did.
Yeah, so what I did in this case, we do the expert, the expert discussion after this. I did a biological reconstruction in this patient. I did a lateral femoral osteochondral allograft combined with a lateral meniscus transplant. And, this is kind of sort of what this looks like. I use a bone bridge for the lateral meniscus. That restored his joint pretty nicely. You can see that in the arthroscopic view. Exactly this high traffic corner. And I do not like to use cell-based procedures in that area because I do believe that there's too much mechanical wear. And then finally, 1 year from surgery, he was back to work in a different position, no pain with ADLs, still has a quad deficit, which is an issue with these type of rehabs. He's doing BFRT for that, and he would do the surgery again. His KUS improved to a 76. So that is what I did. But, how about our experts, Tom and Mike? Do you think I was crazy doing this and somebody who has a BMI of 36?
That's exactly what I would do, Christian. I think you've got mature cartilage and bone being put into a heavier patient. I think a cell transplant would be very difficult, as you mentioned. If that was a BMI of 20, though, I probably would have done a cell transplant with a meniscus allograft. But, that's a big, heavy dude. And I think doing it all at once is the way to go. And I don't think there was a need for a varus femoral osteotomy there because of his alignment. I don't know, it would have made a whole lot of difference in his pain without the cartilage repair. So I would have done exactly what you did.
Okay, great. Mike, what would you say?
I'd agree. I think he's proven his compliance. He's done a great job of losing weight. It'd be interesting to know what his BMI was at that final follow-up. But in acting in the way that you've done, you've given him the best possible chance. And in neutral alignment, 70% of the force is going through the medial compartment anyway. So overcorrecting into the medial compartment, I think would accelerate wear in that compartment. So I think you've done exactly the right thing.
Yeah, that is one of those things that I think most of us really have learned, and I think it's important to say, is an overcorrection into the medial compartment is always a bad idea.
And actually, great.
I think if he was 10 years older, I might have done a lateral uni if he was 50 or early 50s. But at the age of 40, that's still quite young.
So great surgery, great results. But I want to make one point. If you take a look at the preoperative X-rays and on the post-op X-rays, you can see a little bit of progression of OA in the other compartments, on the patellofemoral compartment, on the opposite side. And I don't want to say don't do the surgery. It's absolutely the right thing to do, in my opinion. But it's a big hit because it's not a 10-minute surgery. It's a big surgery. It's a hit for the patient. We will definitely change the environment of the joint. And in your practice, do you have any advice how we can prevent these changes of the joint environment, maybe now or in the future? What would you say?
Yeah, so, thank you for bringing that up, and this is, I think, important going forward. I don't currently have the solution to it. But what I do believe is what we need to do better with, and orthobiologics may be actually an avenue that we can explore in that respect, is we need to add non-inflammatory factors that prevent this chronic inflammatory response that these patients continue to have, and we all know about it down the road, because that continues to drive the tricompartmental manifestation of the arthritis that eventually will lead to the failure of that joint. I hope that in a couple of years I can tell you a little bit more what kind of magical tool to use for that. But at this point, I think we have learned that we actually need to look into that.
Okay, perfect. So now let's take a look at the results of the voting. So what did our audience do? 71% said they would do a chondral repair with cell or non-cell-based technique and meniscus substitution. So, Christian.
Unbelievable. These are 71% of the audience can be my resident tomorrow. This is I love that. This is great, and I think it is one of those things that is fun to see, because these are really difficult patients that you are dealing with, and they can or cannot return to work. So I love to see that.
And that means also that 70% of our audience performs meniscus transplants. That's a lot as well.
Or substitutions. In Europe, I think you perform more meniscus substitutes. In the US, we perform more transplants. That is actually also suggests a very high skill level, because that is not easy. Alrighty, now I think we are moving on to the next case presentation. This is, I give the controls back to my co-moderator, Daniel, and he is going to present the next case to us.
Wow, so the next case, it's a 49-year-old male, a former rugby player, who treated his PCL conservatively during his active career 18 years ago. Now he has increasing patellofemoral and medial compartment pain for 2 years. Again, he takes daily painkillers, so he has a muscular compensated posterior knee instability right now. He's a big guy. Clinical examination is free range of motion. There's painful inflection underneath the kneecap. Medial condyle is painful to pressure. Patellofemoral joint is painful. Patellar grind test positive. Beside a 2+ posterior drawer and a dial test, which is positive in 90 degree of flexion and negative in 30 degree of flexion. His ligament is stable, and he has a straight leg axis. Interestingly, that was his initial MRI he brought to my clinic, 18 years old, and you can see this was the PCL rupture 18 years ago, which was treated conservatively because he wanted to return to sports pretty quickly. And this is the current status. You can see the scar of the PCL, a little bit elongated. You can see especially the medial facet of the patella. There's almost no joint, and no cartilage. And you can see in the sagittal view that he has a lesion on the medial femoral condyle and a degenerative meniscus lesion of the posterior horn of the medial meniscus. So, these are the X-rays preoperatively. And we performed stress X-rays as well. And you can see that he has a 10 millimeter plus posterior drawer on this side in comparison to the opposite side. And you can also see that this potentially can put a lot of pressure on the patellofemoral joint. Straight leg axis. What would you do with this patient?
All right, so now we have live voting. So how would you treat this patient? Would you do a non-operative treatment, a cartilage regeneration with PCL reconstruction, cartilage regeneration with PCL reconstruction and partial meniscectomy, or a posterior stabilized total knee arthroplasty? So while you guys are voting, we are starting the discussion. So I start with Mike. What do you do here?
So again, the industry have really helped us with amazing designs now of PCL specific bracing. And I think that you might be very pleasantly surprised by the use of one of the braces, particularly the ones that are applying an anterior force throughout the range of movement. And if that controls his pain, then if then he would, I think, do well with a PCL reconstruction. And I think, again, he's young enough to want to avoid joint replacement. And so he's got neutral alignment. I don't think there's any benefit to an osteotomy. His slope did not seem excessively reduced. And so I think the PCL reconstruction would be fine with his tibia left intact. And then that medial meniscus, if it remained symptomatic while he was wearing the brace, I think I would trim it. If it was functionally then deficient and you've got a full thickness of the circumference of the meniscus removed, you might need to protect the articular cartilage work that I think you should do with the meniscal transplant or substitution.
Tom, what's your take?
Yeah, it's a real tough case, Daniel. You really are putting us to the test on this one. I agree with Mike, starting off with bracing, just because these are unusual injuries, they're rare injuries, and it's not often that they are so unstable as you've demonstrated here, and that's symptomatic. So I think if the brace is ineffective, which I'm assuming you're going to say, he either hates the brace or it doesn't work for him, then I would agree there's no role for osteotomy here. So with some PCLs, increasing the sagittal slope, you can stabilize the knee. That's not necessary here. And with no meniscus, a PCL injured knee is very prone to medial compartment degeneration. So I think you really have to pay attention to that medial compartment. So I would consider doing all three. And I don't do PCLs in my practice, so I would send him to somebody who is very adept at it. I've seen the jigs and the PCL reconstruction devices that they have now, and they're really becoming almost like an ACL, where they're becoming well enough designed that a good arthroscopist, ligament surgeon can perform a PCL repair or reconstruction, I mean. So I think PCL reconstruction with cartilage work, and I agree with Mike, it's medial compartment that's at high risk with a PCL injured knee. So if there's not much meniscus here, you may need to do a meniscal allograft as well. So I think this is either you do nothing or you do all of it. So that's what I would say.
Daniel,
Can I interject just briefly? So rugby league, as with the case that I showed that needed the arthroplasty, is incredibly punishing. And 50% of the highest league in the UK, the Super League players, have PCL injuries. And it doesn't stop them playing, but this is quite a common scenario for me. And looking after these guys, then I've been fortunate to have been trained in PCL reconstructive surgery. But I think whilst the jigs make it appear to be a straightforward procedure, there is I think that referral to people that are doing them frequently is better than encouraging occasional PCL reconstruction use because of potential vascular injury, compartment syndromes, and it's still a very technically demanding procedure. So I do think that it's not for the occasional surgeon. So if you are very adept at ACLs and spend time working on your PCL technique, great. But I think that I'm aware of a number of cases where surgeons have wished that they had referred patients after very significant limb-threatening complications of PCL surgery in the UK.
Yeah, and I think that's a good word of caution. That's in the interest of time. Sorry, Tom. So this is a good word of caution. I think what is also important is to understand, and I think, Daniel, you pointed that out, that his pain is not just medial, but also patellofemoral. And so therefore, now we have two compartments involved. So let's see what our voting results show. All right, so a lot of you guys, again, would go ahead and do a cartilage regeneration procedure and a PCL reconstruction. Now let's see what my colleague Daniel chose to do in this particular patient.
It's really, the results are totally interesting for me, and it shows maybe a little bit that that is an ICRS event here. But I agree in some points. I talked to the patient a lot, and I said, actually, I do a lot of PCL reconstructions, but I said, I cannot tell you for sure that you are pain-free after a PCL reconstruction and after cartilage regeneration procedures, especially because you have cartilage damage in 2 compartments of the knee. And this guy, he said he wants to have a definitive solution. And so we both decided to go for a posterior stabilized knee arthroplasty.
This is the first big chunk of metal that I'm seeing here that blinds my eye, but this is fantastic. And, I think this is a good choice in that case, right? So this is, there's never really a right or wrong answer. And, Tom, what do you think about it? You do both. You live in both worlds. What would your choice be here?
Yeah, I think what Daniel just mentioned, the discussion that you have with the patient, what's realistic? I mean, that's really the whole thing. I think in my practice, that's one I would not have done a biologic repair on because I don't have experience with PCL reconstructions, and I would have sent that to somebody who does for their opinion. Daniel does a lot of them, so he knows the outcomes. I mean, this is, I think, something that as surgeons that we bring into the discussion, and that's our experience level, our results, what we can accomplish for a patient realistically. And realistically, I think in the end, I might have done exactly what Daniel did and do a total knee replacement because I don't have experience with PCL reconstructions. And if he has, pain in 2 compartments and what he really wants to focus on is not so much stability and function, but he wants to get rid of his pain, for sure he's going to get rid of his pain with an arthroplasty. So I think this is a very unique case. And I think the fact that Daniel has experience with both PCL reconstructions and arthroplasty, as does Mike, I think they're the best guys to see a case like this because they know what they can do with cartilage repair, ligament reconstruction versus arthroplasty. So that's a great case.
Daniel, the word is finally with you.
Well, thank you so much. Great discussion. Absolutely perfect. And so now we have one more case because we already talked about the medial compartment, we talked about the lateral compartment and the global joint. So now we need to talk about the patellofemoral compartment. Christian.
Yeah, that's correct. And before I start this case, I tell you I'm opening my heart to you on this one. You will see why. So this is a 22-year-old female finance student, former athlete in high school. Has a very high activity level. She hikes currently, she does Pilates, insane fitness classes. And when I saw her first, she had a 1 to 2 year anterior base knee pain, swelling, pains with walking, stairs, increasingly with ADLs, no clearly identifiable injury, neither in the past nor recently, and no history of patella dislocations, but occasional subluxation events that she does report. And you see the x-rays here on the AP is really relatively non-contributory. You see maybe a tiny little bit of a lateral tilt of patella, although this is not a great merchant view. And her Cotton and insole ratio, as you can see here, is elevated. So she has, when I get an MRI on her, this is her trochlear lesion that she presents with. The patella overall still looks very good. She has a TTTG of 20, an elevated Cotton and clearly an elevated insole-Salvatio ratio. Her patellofemoral engagement index is at 32, all indicating a patella alta. And the MPFL status is okay. So not so much a patellofemoral instability issue from the ligamentous side, but she clearly has a patella alta. So we went ahead and basically addressed both of these things. I did a tibial tubercle osteotomy with an anteriorization and a slight distalization, and I fixed the chondral defects in the trochlea, as you can see here, using a Macy. She recovered from that very well. She was extremely motivated. And then about a year later, she comes back with, starting pain again. And she presents with the MRI that you see in the top left corner. I took her back to scope her, and this is what I saw. The one side of the Macy looked good. The other side partially, but partially didn't take. So at that point, I decided to try to rescue this with a microfracture. And that worked well for about a year. After a year, she started coming back with pain again. And now you see the MRI, on the left side. Not only does she still have subchondral changes from the microfracture, even though intermittently she was asymptomatic, but now she also has a patella lesion. I had a long discussion with her about what to do here, and her choice was, well, I want to have this repaired. And so we took her back to the operating room. You see that metal stick going into the lesion. That's actually a probe that goes underneath the articular cartilage flap there. And you also see that the trochlea lesions actually are well taken and repaired. So I did an additional MACI to the patella. This is big surgery number 2. And so this is what she was 12 months later. So the trochlea still has a tiny little bit of a cyst there, but otherwise looks really good, and the patella looks good. 18 months later, she comes back again with swelling and pain, and then I walk you through this MRI, and you see here is a slight intralesional osteophyte, and then you can see basically her patella starts breaking down again. So at this point, we have a 25-year-old status post 3 cartilage repair surgeries, biological failure of the patellofemoral joint. I could not explain this any differently. And she's at the end of her rope. So what do we do?
So great presentation. So we will ask our experts, what would you do in this case? Tom and Mike.
So I'm curious, Christian. One thing I've found out in the patellofemoral joint, and that's activity, is with these MACIs, I don't really let people start getting really active until 18 to 24 months post-op, because I find that the repair, it's a shearing surface, not a compressive surface. It's thicker cartilage. It's 5 to 7 millimeters thick versus 2 to 3 millimeters thick. It's slower to mature. So when I've seen them go bad, it's usually because patients become too active too soon. And so did any of that go on with this woman? Was she sort of just like always chomping at the bit to get to the next level of activity? And do you think that she just was too active and had progression of disease or failure of her grafts?
Yes, and we talked about that. Then after the second one, clearly not. She was really to the textbook. Before we go on, however, we want to do the live voting. So we want to ask you, or what would you do? Daniel?
Continue to non-operative treatment, revise the patella with another technique, try an orthobiologic injection with PRP or BMAC, or do a patellofemoral arthroplasty. And now the word is back to Mike. Mike, what would you do?
So then, I may have missed it, but was her rotational profile normal?
Profile was normal, and she didn't have any valgus malalignment.
Okay, so sometimes when you get excessive wear, there could have been a rotational issue, but you've excluded that. And so I'll stop at that, and let's see what the audience are going to suggest.
Well, why don't we just say what we would do, though? Is that where you want to go with this, Christian? What Mike and I would do?
Yeah, please tell me, because I was in this situation about a little bit more than a year ago, and I tell you, I had to ask a lot of questions. So what would you do here?
Yeah, I think this is one of the few places I would do. You've already realigned it and decompressed it, and she's stable to her patellofemoral joint. I probably would have used allografts here, bipolar allografts. And I probably would have done matched grafts from the same donor, female grafts. And I would try to do an inlay technique on the patella and not an onlay technique. So I would put a dowel in and try to anchor it and maybe even a compression screw, a headless compression screw. So I think that's one of the situations where you've tried twice, you've done a surface treatment for a surface problem, everything grew well, and then she's got some inherent biologic failure mechanism that we don't understand. So I would go with different biology, somebody else's.
So I
Mike,
think
what about you?
Can you remind me, the trochlea was surviving well, or had that failed in addition? Christian?
Can you repeat the question, please?
Had the trochlea resurfacing failed as well, or had that remained in reasonable
No,
condition?
that actually
It was
looked fine. So this is a classic case of where basically the lesions were piecemealing one after the other. You know, every time I looked at them, I repaired one, the rest, I scrutinized the rest to determine if I just need to do more. And every time it's like, no, this looks fine. And, you know, particularly the patella. I was actually looking at that, prepared to potentially address it too, but it looked totally fine.
So, are some patients whose biology is just not gonna do, and so allograft is possible. Some patients are a little worried about that. It depends on which country you work in. There are some focal arthroplasty options that you could use, and given the size of the lesion that you've got there, there is a device called a biopoly device, which is FDA approved, and it has a patella resurfacing option, which has minimal drilling in a similar fashion to the way you were saying, like an inlay device, Tom, and then a cemented mixture of high density polyethylene and hyaluronic acid that creates a hydrophilic substance rather than the hydrophobic normal high density polyethylene, and it's got very good wear characteristics. So if your trochlear side looked like it was behaving and the patella was struggling, because it's always the most punishing environment, I think, then that's another option to discuss with the patient, because I don't know what your supply times are like in the States, but we often have to wait for quite a significant period in the UK for allograft to become available. And it may be that in that time, the roughened surface on the patella could ruin what was a good trochlea.
Shall we do the voting results? So we'll see what we get.
So 60% would say they try an orthobiologic injection with PRP or BMAC.
So this is really interesting, because I had all these discussions with the patient. We are 50-50 now, actually. I had all the discussions with the patient, and she wanted a definite solution. We were discussing bipolar allograft, like Tom suggested. I discussed with her PRP or BMAC injections. The problem is, she said, listen, you know, we'll do this, I'll be fine for another 6 months, and then I have to do something again. I don't have the time, I'm tired, I want to move on. So what I did here is this. I did actually a patellofemoral arthroplasty, which none of you guys would have chosen. And interesting enough, she is the happiest she's been. And at this point, she is back to pretty much most of her activities, as long as, and she does understand that this is not for the high impact situation. So this is not one of those focal implants that Mike was talking about. This is a inlay arthroplasty, minimally resection of bone here, and this is also one of those that I do quite frequently in combination with instabilities. And we'll have to see, you know, the jury will be out on this case. She is about 1 year out now, not quite. She has no pain. She is back to her Pilates and low impact fitness classes, no effusions. She actually says she feels the best in 5 years, and we'll see where she gets with that.
Well, great talk. What would you say? Is it a good solution? Mike, Tom, what would you say?
I do a lot of these patellofemoral arthroplasties as well. That's my last option. I think I would have stuck with my focal allograft try first. They're kind of squirrely, these patellofemoral patients, even when you do a patellofemoral arthroplasty. So I got my fingers crossed for Christian. I would have tried the biologic first.
Okay, and I think Mike,
I've had.
Sorry, go ahead.
Yep, I've had quite a similar patient, and I think for me, there's 62 orthopods in our department. 5 of us do partial joint replacements, so that we get sufficient numbers to help improve our outcomes. And there are 2 that do patellofemoral replacements in isolation. And so I wouldn't have carried out that patellofemoral replacement myself, but I often work with my colleague. He does the patellofemoral replacement, and I'll do the tibial osteotomy work. So I think it's a great solution. And the patient was given options and she chose the option of her preference. So that's patient-centered care, which is the kind of the gold standard that we're aiming for at the moment.
I agree with that.
Well, this is obviously what this is obviously. Sorry, Tom. This is obviously what I was thinking, and that is obviously what makes us feel somewhat better. But you know, you always have in the background this thought, basically, is this really the right thing to do? And one of the major drivers that I have learned over the last 20 years working in this field is, I think sometimes we have to understand that patients are simply getting tired. These recoveries from these procedures are hard, are very hard. And, you know, I have increasingly taken the clue from the patient here when they say, listen, I'm done with this, then there's no chance, the way I see that we can really make them substantially better. Because they simply lose the participation. And once we lose that, I think then we have lost the patient's success. And in this case, basically, she needed a quicker solution, so this is why we went that route. Did you want to take that one question?
Yeah. And let me ask you one question before that. And Mike made a great point before when he talked about the rotational alignment. So what's the role of high femoral antetorsion or high tibial external torsion in those cases? So do you routinely perform torsional CT scans in those cases, and do you address it in combination with your patellofemoral arthroplasty? And if yes, what is your cutoff value to do so?
Yeah, so this is a really good question. You know, so the one observation that I have is the torsional, you know, malalignment is really mostly an instability problem. You know, and if I have an instability patient who is coming in, the first thing as I do is I check hip rotation, and if that is asymmetric, they'll get a rotational CT. And or if it is so isometric between internal and external rotation, they get a rotational CT, and then yes, that will be taken into account. Whereby you know, not necessarily with a rotational osteotomy, I basically look for a combined internal rotation above 25 degrees as a minimum. Before I do a derotational osteotomy. Often they are then also in combination with the valgus, which you can address at the same time. This is certainly not the case in this patient, because most of the time these patients also have significantly different wear patterns on the patella. They are not typically central wear patterns, they are really much more on the periphery.
Mm-hmm. And what's the role of lateral lengthening procedures and an additional MPFL reconstruction maybe in those cases?
Yeah, so that is something that I think needs to be assessed whenever you're doing a patellofemoral reconstruction or a replacement. You know, so I do actually a lateral approach so that I can do a lateral lengthening approach to start with. And then that becomes an automatic thing once we are putting the patella back in. You'll assess your actual tracking and adjust the lateral retinaculum along you know, what that knee basically gives you. And interesting enough, even in patients who don't have any significant you know, alignment or instability, typically I end up lengthening the retinaculum by about 5 to 10 millimeters, doing it that way. So yeah, I think this has a role, and I think that needs to be considered.
Okay, perfect. So we have one last question from the audience. Would you consider subchondral bone grafting in addition to cartilage procedures in this patient with a patellofemoral lesion?
Let me put that question straight to Tom, because you're the expert in that area. What would you say here?
What was the question again? I didn't hear all
of it. Would you use additional subchondral bone substitution, either by you know, bone grafting or substitution with BMAC or something like that, when you're doing your cartilage repair in the patella?
Yeah, I usually don't. The only time I'll do anything different is if I see the bone is very sclerotic or it's being drilled or something like that. I will. I'll do what's called a sandwich technique if I'm doing cartilage repair without bone grafting. So what I'll do is I'll use a high-speed burr under irrigation, remove the abnormal bone, just shave it down. But what that then does is it exposes all the marrow, subchondral bone. And so we're going to mix our cells with the marrow cells. So what I do is a sandwich technique. layer 1 is facing out and it seals the subchondral bone, and layer 2 is down. So I have 2 layers separating the marrow space away from the cartilage repair. But I usually do not add, subchondral bone infiltrate. But if there are cysts and things like that, yes, I will remove all that abnormal bone and use autologous bone from the patient's knee, usually from the tibial tubercle osteotomy site, and apply it there. So unless there's cysts or some really abnormality of the bone, it just doesn't look healthy, I will leave it alone. But if there are subchondral cysts that you know from MRI scan pre-op, or cysts you find intraoperative, or abnormal bone, then I will do something to the bone as well.
Thank you very much. And with that, we are coming to our conclusions and key takeaways. And I'll, tell you what I consider the key takeaways of this session today. Number one is these are difficult cases. And you have to really consider multiple different areas that basically sends us through the entirety of sports medicine and into adult reconstruction in order to come to the right conclusion. And you see, there's sometimes different ways to skin a cat. There's not always one correct solution, but I think what is really important, and we have seen that in most of our cases now, is do discuss with the patient what your approach is and what their goals are to align them with your goals when you're operating on them. I think this is one of the real key elements here. Daniel, what's the key takeaway for you?
Well, the key takeaway for me is maybe that there is not always one solution. We talked about patient expectations a lot. We talked about talking to the patient, sitting down with them and discussing what is the right procedure for the right patient. And that's really interesting to see that even guys who perform a lot of cartilage procedures in the joint, a lot of osteotomies, a lot of arthroplasties, sit down with a patient and discuss what is the expectation of the patient, what is the expectation of the doctor, and then make a good plan together. And that's really important in my mind.
All right. Well, thank you very much. I want to point out a bonus program hosted by our scientific partner On Stage by Eva Roos on exercise and knee surgery. And we want to thank our 2 experts. Tom, Mike, thank you very much for your time. I thoroughly enjoyed this. We thank our viewers, our sponsors, RegenLab and the On Foundation, and of course my co-moderator, Daniel.
Perfect, Christian. I would like to thank our experts as well, and I would like to thank you, Christian. It was a lot of fun to do this with you together. Thank you for doing this with me. Thanks to Winglet for this outstanding organization here. It was really great. And here, goodbye to the audience. Goodbye to all of you from the beautiful city of Munich.
All right, servus.
More than 70,000 patients with osteoarthritis in 7 countries on 4 continents have already been treated with a program for which she and her team won the Value-Based Healthcare Prize in 2019. It is her passion to advance the frontiers of knowledge to improve the quality of life of those with musculoskeletal disease and to improve healthcare delivery for these conditions. Her research findings are the result of teamwork and long-standing collaboration across medical professions. Professor Eva Roos is professor at and one of the founders of the Center for Muscle and Joint Health, Department of Sports and Clinical Biomechanics, University of Southern Denmark. She has published more than 250 articles, and we could call her the Queen of Physiotherapy. She will enlighten us with her view on the importance of exercise for the regeneration. Please welcome on stage Eva Roos.
why am I here? When I look around, I'm not sure that I fit in, because I'm not a man, and I'm not a surgeon. And for that reason, I have a feeling that my message may be somewhat uncomfortable. But I am a big fan of regeneration and treatments that support the body's capacity to heal. My many years in research have confirmed what I suspected already when working as a clinician, that surgery is not always needed when you have a knee problem. You can actually get comparable results with exercise therapy. Treating with exercise therapy can save many common knee surgeries, their costs, and their associated risks without compromising the results. So why am I here? I'm here to inspire you to think differently when you develop future treatments for people with knee problems, because neither surgery nor exercise are perfect treatments, so there is an absolute need for better treatments. I grew up academically at Department of Orthopedic Surgery. That is a very powerful and executive environment, and I loved every inch of it. It made me feel very important to be part of this environment. So we saw young athletes who had torn their ACL, we saw middle-aged people who had ruptured their meniscus, and we saw older people who had developed osteoarthritis. And you could see the expression of hope on their faces when they were presented with the option of having surgery, because they wanted and they thought they would get their old knee back, and so did I, and I'm sure so did the surgeon. So this feeling of hope is very powerful. It's actually so powerful that fake surgery has been shown to be just as effective as real surgery. And one way you can fake surgery is to make skin incisions and never insert any instruments into the joint. So here you can see the result, the improvement from real arthroscopic partial meniscectomy. 30% improvement on a group level. And what about fake surgery? Well, 30% improvement. No difference between the two groups. I have always been a runner. It's an important part of my life. It makes me feel very good. Many years ago, I suddenly developed what felt like a locked knee and became a patient. That was devastating to me. I remember I couldn't bend the knee enough to step up from the street to the sidewalk. And I couldn't care for my kids the way I wanted to. It affected my whole life. And I was diagnosed with a meniscal tear, and I was offered surgery as part of a study. That study included that I would have to leave the operating table, work out on a Stairmaster with cords sticking out from the knee joint before going back to the table and finish off the meniscal surgery. That sounded so awful that I decided not to have the surgery, despite not being able to live my life the way I wanted, and despite having to say good morning to the surgeon every day, who got more and more desperate in finding patients for his study. But much to my surprise, I got better after a few weeks. My mechanical problems resolved, and I could return to running and a normal life without surgery. This was in the mid-90s, and I started to question if knee surgery really was necessary to resolve mechanical problems of the knee. Because if you see a meniscal tear on MRI or in the arthroscope, and you see the flaps and the pieces that can be hanging there and can come in the way when the knee moves, it feels pretty obvious that you need to do something surgically to fix it. And this is a really convincing story, but is it true? So we do studies where we let chance decide if people are treated with exercise therapy or with surgery. In one such study, we included people who were diagnosed with a meniscal tear. So prior to treatment, we asked them how much problems they had with mechanical or other symptoms like catching, clicking, pain bending, swelling, and stiffness. And 25 to 60% had at least moderate problems with these symptoms. We asked them again after treatment, and they were much better. It was a much smaller proportion who reported having these problems. And guess what? This is in the group that was treated with exercise only and did not have the surgery. So I think it is time to bust the myth that surgery is needed to resolve mechanical problems of the knee. Let's talk about ACL injury. This is a devastating injury that most commonly happens to young athletes. For nearly every other, it is a career-ending injury. And for those who do return to sport, many of them injure themselves again. And this is the fate of those who have had their knees surgically reconstructed. This is myself, together with Richard, Harold, and Stefan. 2 orthopedic surgeons, 2 physical therapists. Together, we have suffered 3 ACL injuries. We led a study where we let chance decide if young athletes with an acute ACL tear were treated with reconstructive surgery, followed by exercise, or by exercise only. This is a very controversial and complex question. And it took us more than 10 years from first thinking about it until the results were published. And then we celebrated with champagne. I think we needed it because we experienced many barriers along the way, including the first young surgeon coming on board being so harassed that he quit the project and became a hand surgeon instead. And the second young researcher who came on board and actually finished the project, he was never invited to any conferences to share the results. So what were the results that no one really wanted to hear about? Well, we found that after treatment, 9 out of 10 have improved. They feel better. But actually, only 5 out of 10 feel good about their knee. And for 1 out of 10, the result is so poor that they feel that the treatment has actually failed them. But the controversial finding was that there was no difference between the 2 treatments, surgery or no surgery. Osteoarthritis. That imposes a huge burden on the individual and on the society. It's very common. It's more common than other chronic diseases such as diabetes and cardiovascular disease. And we often think about osteoarthritis as a disease of the elderly. But if you had a major knee injury as a young athlete, actually about half of them develop osteoarthritis already in their 30s. But thankfully, there is a good treatment for advanced stages. You can replace the joint with metal and plastic. And this is really, really a good treatment that has improved the quality of life for millions and millions of people all over the world. It has been considered senseless to try the effectiveness of total knee replacement. It has been considered just as senseless as testing if you need a parachute to survive if you would jump from an airplane on a high altitude. Because after all, you know, joint replacement is one of the most significant advances of the 20th century. And don't we already know that they are effective? Well, we thought there was the need for this parachute trial. So we let, again, chance decide if mostly overweight and obese people with advanced osteoarthritis, either all eligible for surgery, either have their joints replaced with metal and plastic, followed by a 3-month rehabilitation package, or have the rehabilitation package alone. The rehabilitation package had a focus on exercise, but there were also other components. So people were taught about osteoarthritis as a disease and what they could do themselves. Those who were overweight and obese got to see a dietitian, and the surgeon could prescribe analgesics and orthotics if they thought that would be beneficial for the patient. And what did we find? Well, we found that the results were not as clear-cut as we had expected. We found that if you have the surgery followed by rehab, you can expect a greater pain relief. It's actually so large that 85% find it clinically relevant. But it comes at a price, because 1 out of 10 experience a serious adverse event, mostly blood clots and infections. Most of these can be resolved very easily with additional surgeries or additional hospital stays. But they can also lead to lifelong consequences and even death. If you, on the other hand, only had the 3-month rehab package, you also experienced a pain relief. And quite surprisingly, it was large enough for 68% to find it clinically relevant. And that was enough for 3 out of 4 overweight and obese people with advanced osteoarthritis to postpone surgery for at least 1 year. And at 2 years, still 2 out of 3 patients had not had the surgery. And there were no serious adverse events. So in summary, common knee surgery is unfortunately not as effective as we would like it to be. And surprisingly, exercise therapy is much more effective than we thought it could be. Exercise has many benefits for people with knee problems. It can improve joint stability in those with an ACL tear. It can reduce mechanical symptoms in those with a meniscal rupture. It can relieve pain in those with osteoarthritis. And in all knee patients, it will improve the function and the quality of life. So better treatments are needed, because common knee surgery or exercise therapy have their benefits, but it's not good enough. You need to develop new and better treatments. And I would like to encourage you to include the power of exercise into these future treatments. Because exercise is powerful and our bodies are amazing. It can actually be enough, even for an ACL-injured athlete, to return to tough sports. Meet Dino Djubic, who is an Australian soccer player. He tore his ACL and decided he wanted to return to sport without having it reconstructed. So he had everyday intensive physiotherapy and exercise therapy for 2.5 months, and he returned to play at 5 months. But just as Dino says, recovery and return to sport after an ACL injury, that's not only about the knee, it is also what's in your head. So I have a little confession to make. This is me. And because of our studies, I choose exercise therapy when I tore my ACL a few years back. And interestingly, preliminary results from our current research shows that the ACL actually can heal in those who do not have the surgery. Maybe I'm among those. I don't know. That's another story. Thank you.